Yes, so very good evening. Today we are going to discuss common cloaca, like how to manage common cloaca. So we'll do it in a very, uh, I have mentioned all the details, so I'll just discuss, and then if we have any doubt, then we can discuss it in the comments also. So cloaca is a wide spectrum of defects, as we know, which in which there is a common denominator. We can say that is a single opening in perineum. So that common channel length varies from uh, 1 to 10 centimeter, and average it is around 3 centimeter, which is the like seen in the most of the cases. So around one third of these patients have a very dilated vagina which is filled with fluid, urine and or mucus, and we do not know whether there is any valve mechanism, because despite that the fact that the common channel is never atretic, it despite that it doesn't drain. So this one third of these patients have a hydrocolpos, and most of the system with hydrocolpos have a duplicated Mullerian system. So what can be the complication of having a hydrocolpos? So this hydrocolpos, as it will increase in size, it will cause compression in the at the level of trigone, and it will cause VUG obstruction leading to megaureter and hydronephrosis. And if this hydrocolpos is left untreated or undrained, it can infect, and it can cause pyocolpos formation, which will eventually perforate and lead to scarred vagina, and surrounding inflammation will affect the future reconstruction. So around 40 to 60% of these children will have a double Mullerian system, where they will have two hemiuteri and two hemivagina. So this septation can be partial or total, symmetric or asymmetric, depending upon the anatomy, which is variable in different cases. So asymmetric type will have a unilateral atresia of Mullerian structure. If it will go unrecognized, there can be a collection of menstrual blood and at the puberty, and due to the retrograde menstruation, it will cause spill into the peritoneal cavity. And the double Mullerian system will have its own obstetric implication, depending upon how large the hematocolpos is. Then few are the urological abnormalities. So around 90% of these patients will have some form of urological abnormalities that we have to find out, which can be either a renal agenesis, either a horseshoe kidney, or ectopic ureter, or duplex, or there can be a VUR, and there can be a secondary there can be a hydronephrosis and megaureter secondary to the VUR, or VUJO secondary to hydrocolpos. So what are the goals while we are treating the common cloaca? So these are the goals. What are the goals? These are the goals: urine control, bowel control, sexual function and obstetric potential. Sometimes obviously these are achieved depending upon what is the length of the common channel, and sometimes they are partially achieved. So Penna's teaching is that after the age of 3, these things should be achieved. If there is a smaller common channel length, then these adequate reconstruction can be done to achieve this. And if there is a bad common cloaca, that means there is a common channel length is more than 3 to 5 centimeter, then these kids will have to have on bowel management program for a clean diaper and CIC, to have a dry urinary system, so that they will not have continuous leaking. Then if a neonate presents, then how we will assess? So assessment you will separate the labia, and you will find that there is a single perineal orifice. So we can divide it into two groups. One is good looking perineum, second is bad looking perineum. So good looking perineum is one where there is a well formed midline groove with a well located and clear anal dimple. This shows that this neonate will have good sphincter mechanism. And if there is a flat bottom with no traces of a good sphincter mechanism, then we can say it will be associated with poor functional prognosis. Sometimes These baby will have hypertrophic folds of skin along with a single orifice. This will give a false impression of phallus, and they are misdiagnosed as DSD, that is differentiation of sexual differences of sexual differentiations. So in the first 24 hours, as Penna's teaching, we should not have to do anything surgical intervention. We have to rule out other abnormalities. So we have to rule out other abnormalities. We have to do a USG, KUB and pelvis to rule out urinary tract obstruction, to see whether there is any hydrocolpos, to look after hydronephrosis, megaureter and a cystic pelvic mass, which most of the time radiologic people can misdiagnose it. That's ovarian mass. So it is mainly a hydrocolpos, so which is compressing the bladder and causing hydronephrosis and megaureter. So plain X-ray abdomen is sometimes is also helpful. So if this may go unnoticed, sometimes can lead to unnecessary procedures like ureterostomy, like vesicostomy, nephrostomy. So if one will drain the hydrocolpos, majority of these problem will subside, and these procedure which are unnecessary and will not need. So the bottom line is, if there is a hydrocolpos, first drain it before attempting any urological intervention. Then one need to do a 2D echo to rule out cardiac issues, to rule out TEF by putting a NG which will coil, and then spinal ultrasound that can be done to rule out tethered cord within the 3 months of age, because after that you will require a MRI, and a plain radiograph will help in finding out the status of the spine and the sacral ratio, which itself has a bearing on how the bowel will function after the reconstruction. So management include a descending colostomy with a mucus fistula that is completely separated from proximal fistula. So Penna's teaching is that they never recommend a loop colostomy. So there should be a adequate distal bowel we have to leave, and because later in the life it will also help if there we might need a bowel for vaginal replacement. So Penna discourages loop colostomy, as we have already discussed, and if adequate drainage of hydrocolpos will done with the help of pigtail drainage, then majority of these kids will have a good recovery and will be ready for a definitive procedure after some time. So this we have already discussed, and then definitive reconstruction depending upon the length of the common channel. So Penna has two groups that he has divided. So group A and group B. Group A, where he has put all those neonate where is the common channel length was less than 3 centimeter. So he mentioned that only posterior sagittal approach helped him to do all the reconstruction. For all the neonates or all the children where the common channel length is more than 3 centimeter, he has to do posterior sagittal procedure along with the laparotomy. So the difference of the time taken for the entire surgery, and one can see there will be a extended post-operative stay also, and one can see the in terms of outcomes. In group A there will be 66% in their study, and in 36% patients will be are able to achieve the voluntary bowel movement. Similarly, one can see the difference in the urinary continence. So first we are going to discuss cloaca with common channel having a length of less than 1 centimeter. So the ideal procedure is PSAR-BUP. So we will do the mobilization of lateral and posterior wall of vagina after doing the traditional mid-sagittal separations of the structures, and the suturing of the edges of the vagina to skin of neolabia. So without disturbing the common wall between the urethra and vagina, and it will help in achieving the excellent bowel and urinary control, provided if there is normal sacrum and the spine. Although it will have mild female hypospadias, but it do not need CIC majority of times, as urethral meatus is visible and we do not have to worry about it. Second is cloaca with a 1 to 3 centimeter common channel. So this is the group which is having the majority of the cases, and it is associated with good prognosis. So around 20%, less than 20% require CIC after reconstruction. And bowel function, obviously we have discussed, it will depend upon how is the spine and the sacrum. So preferential age of repair is around 1 to 3 months of age. So one has to do posterior sagittal approach with total urogenital mobilization, and it will help in achieving good function with the cosmesis. As you can see here, the rectum is mobilized and put in the at the place where it should be, and there is a total urogenital mobilization that has been done. So we have discussed operative steps also here. You can take a screenshot whenever you are watching this video and can read all these operative steps where we have discussed how to do reconstruction of the common cloaca where there is a common channel length of 1 to 3 centimeter. So now we are moving towards a cloaca with a common channel length of 3 to 5 centimeter. One has to do similar procedure like prone position, start with posterior sagittal approach, and after doing this rectal mobilization, then one has to do extended trans abdominal urogenital mobilization. So that means laparotomy is required. So with laparotomy we have to dismantle all the attachment and completely mobilize it as a unit. So even after all these maneuvers, if one is not able to mobilize urogenital sinus, then there is a need of carving of the pubic cartilage. So if tension-free anastomosis is not possible despite this, then one has to do this where we do the resection of around 50% of the posterior of the pubic cartilage, and it allow more direct trajectory of urogenital tract without compromising the pelvic stability. And it also helps in tension-free anastomosis between the urethra and vagina with clitoris and neolabia. If this is not enough, then the next step is separation of vagina from the urinary tract that we have discussed in the form of flow chart. Again, you can take the screenshot and can read and have a better idea how this procedure is done. And the last but not the least, we are going to discuss a brief about vaginal switch. We are not going to discuss vaginal replacement procedure here, that I will do with a separate video. So in this procedure, the blood supply of the entire switched vagina, so there are two hemivaginas, two hemiuterus. So one hemiuterus is discarded with the preservation of the ovarian tissue. So in this procedure, the blood supply of the entire switched vagina will depend upon the preservation of the blood supply of opposite hemivagina. Here you can see we have resected this hemivagina and this part, and now this is like completely mobilized here like this, and this is created a single unit. This is called as vaginal switch maneuver. So I will also put the link of this paper that we are discussing here, and also the link of the video of Dr. Penna, so that it will have a better understanding of this topic of common cloaca. Thank you.